May is Skin Cancer Awareness Month. Every day, close to 10,000 Americans are diagnosed with skin cancer. Research indicates that 1 in every 5 Americans will develop skin cancer by the age of 70. And to help us understand more about skin cancer, we welcome dermatologist Dr. Wasim Nasir. He's a medical doctor at the Dermatology and Cosmetic Center of Flint. And thank you so much for joining us here on First at 4, Dr. Nasir.
It's a pleasure. Thank you for having me, Dawn.
Yeah, those of us who, what we know about skin cancer, who we're not medically trained, know that there are 3 main types of skin cancer. Is that correct?
Correct.
Describe for us what those 3 main types of skin cancers are.
Sure. So there are 3 different types of skin cancer most commonly found. The most common one is basal cell carcinoma. Over 2 million are diagnosed every year. It's a locally aggressive tumor. Very rarely does it metastasize. 1 in 35,000 will spread. The second most common type of skin cancer is squamous cell carcinoma. That one does have the propensity to metastasize if left untreated. And then the third one, which is the one that we're all most fearful of, is the one that we call melanoma. And melanoma is one of the blue tumors that can present with metastatic disease, and we never unfortunately find the primary. And it's a very aggressive tumor. So any of the moles that are changing that you had should definitely be evaluated.
And how are skin cancers diagnosed? We go see, of course, a dermatologist, but how are they diagnosed?
So if you have a new lesion that presents, if it's scabbing or flaking or crusting or itching, or if it's painful, or you have a lesion that comes about and every time you pick it off it just comes back, that needs to be evaluated. We worry about squamous cell carcinoma in those instances, or sometimes basal cell carcinoma. When we talk about melanoma, most commonly it's a lesion that has it's a mole that's changing. And for melanoma surveillance in dermatology, we talk about the A, B, C, D, E's of mole surveillance. So A stands for asymmetry, B for irregular borders, C is for different colors, D is if the diameter gets bigger than 6 millimeters, and E, which is the most important, is if it evolves. If it changes, bleeds, ulcerates, anything like that, you should definitely come in and see us.
Would you consider those to be the red flags when a person should go and see their dermatologist? Now, let's talk about how the disease is treated. Is it treated the same way most cancers are, through radiation and some chemotherapy treatments?
That's a really good question. So for basal cell carcinoma, if it's local, we just surgically remove it, typically by doing Mohs surgery, if it meets the AUC criteria, and that's something that your dermatologist would talk to you about. If it doesn't meet the AUC criteria, then we usually excise basal cell carcinoma out. If the tumor is so aggressive that it metastasizes, we do have FDA-approved medications like vismodegib that we could prescribe to patients. And if it's locally aggressive, we have sonodegib. For squamous cell carcinoma, very similar to basal cell, we try to surgically remove it, but unfortunately, if it metastasizes, we do have chemotherapy and now immunotherapy that can deal with it. Melanoma depends on the Breslow thickness. So how deep the melanoma is invading is going to dictate the stage and the prognosis of the melanoma. If it's what we call melanoma in situ, or less than 0.8 millimeter Breslow thickness, we can surgically remove it. If it's greater than that, then sometimes we have to do sentinel lymph node biopsies to determine has it metastasized. And in those situations, again, chemo, immunotherapy are the standard treatment options.
And I mentioned at the onset of this interview that 1 in 5, by the time that they reach the age of 70, will be diagnosed. Who's most at risk?
Great question. So number one, most importantly, if you have a family history of skin cancer, it's definitely worth establishing care with your primary dermatologist and letting your family practitioner know about it, or your primary care physician. Number 2, if you burn more than you tan, so you go outside and you get sunburns and you burn more than you tan, that's also going to be putting you at risk. And the number of sunburns that you have, also if you have risky behaviors like you do sun tanning, or if you have occupational exposures, are you in construction, are you a truck driver, are you working outside, or a farmer? So your occupation can play a role as well.
And let's talk very quickly about, there are really no, I guess, true preventive measures, but there are some things you can do to lessen your risk of developing it. Most of us love to be outside in the sun. It provides vitamin D that we need. But it can also be the sun, and the UV rays can be harmful. So how can we protect ourselves when we're outside? My husband's a truck driver, so this is personal. So how do those truck drivers
So what you need to tell your
themselves?
husband is he needs to be putting on, and everyone needs to be putting on, an SPF of, my rule is 30, 60, 90. So you need to apply an SPF of 30 or more, 60 minutes before you go outside. That's the biggest mistake that patients make. They'll go outside and then they'll apply the sunscreen. It's not going to work. And then if you're outside and active, walking, running, cycling, playing tennis, what have you, try to reapply it every 2 hours as well.
Okay, this is great information, potentially life-saving information for someone.
It's my pleasure.
Dr. Nasir, thanks so much for coming in and sharing
Yes.
with us on First Step Forward.
Thank you for having me. It was a pleasure.